Thank you all for attending today's webinar. Just going to do a brief introduction before Rohit starts. So my name is Nick and I'm the support specialist with 80 Instruments. Today I am joined by my colleagues Amy Chi and Parimal Kacha, both senior sales specialists with 80 Instruments. Just a few housekeeping rules before we begin. You can ask questions in the chat and in the Q&A. If it's something that is quite trivial, our team will answer them for you properly. Otherwise, just wait till the end of the webinar and Rohit will be able to answer them. So without further ado, we are here obviously joined by our guest and our lead speaker, Dr. Rohit Ramchandra. This webinar will be titled Pressure and Flow Rate Studies in Large Animals. For Dr. Rohit, throughout his career, he has been interested in the mechanisms controlling sympathetic nerve activity during normal physiology and during pathophysiology conditions. He undertook his PhD at the Department of Physiology, University of Auckland, investigating the role of sympathetic nervous system and nitric oxide in the control of blood pressure. His interest in the possibility that the differential control of sympathetic nerve activity may be regulated by four brain areas led him to undertake his postdoctoral studies at the Flowrate Institute of Neuroscience and Mental Health. Together with his mentor, Professor Clive May, he published numerous papers investigating the reflex control of directly recorded cardiac sympathetic nerve activity in heart failure. He relocated back to Auckland in 2014, where he is running his own lab investigating autonomic control of the circulation in ovine models of hypertension and heart failure. So without further ado, Rohit, you can take it from here. I'll just stop sharing my screen.
Thank you, Nick. So I can't share my screen at the moment.
Just looking into this now. Okay, you can try that one.
Great, thank you. And I'll just confirm you guys can see my PowerPoint slides.
Yes.
Great, thank you. So I'll just start by thanking Nick and Amy, who both kind of very graciously invited me to talk a little bit about my studies. So as from the introduction, I've done a lot of studies, mainly in the cardiovascular space, and one of my big interests is in autonomic control of the circulation. But in the last maybe 4 to 5 years, well, I'm still interested in autonomic nerves and autonomic nerve activity. Blood flow has become quite a big part of my research questions. And so I'm going to give a little bit about a background about measuring blood pressure and blood flow, and then go on to talk a little bit about some of my work that's using these tools to try and answer what I think are incredibly important research questions. And so just a brief outline of the seminar. The first bit might be incredibly basic in general, but I'm just going to raise the rationale that most people would have, and definitely I have, for measurement of arterial pressure as well as blood flow. I'll talk a little bit about tips for implantation of these pressure probes, as well as talk a little bit about instrumentation for these flow probes. I'm not going to go into too much in depth about either of these, because I think there are a lot of other incredibly helpful tips, both from 80 Instruments as well as from other companies or manufacturers who, for example, for Transonic, that really cover instrumentation that's quite specific to different animal models. I'll then go on to move to talk about a model of heart failure and how one of the tools, which is arterial pressure, was used to try and get some data, and then move on to an ovine model of renovascular hypertension, and kind of highlight how the use of the transonic flow probes really kind of helped answer some important research questions. So arterial pressure effectively reflects the combined effect of both the force of the heart, in other words, the amount of blood ejected from the heart, as well as the resistance of the vasculature. If you are a cardiovascular scientist, you're interested in cardiovascular physiology, I think measurement of arterial pressure is incredibly important. And it tells you a lot about the state of the cardiovascular system. Historically, arterial pressure is measured either indirectly or directly. And by directly, I mean effectively having a catheter that sits inside the artery that can directly measure pressure. If you are an experimental scientist, which is what I am, I think it becomes, especially if you use animal models of cardiovascular disease, it's becoming incredibly hard, I think, to publish stuff where you might have indirect measures of arterial pressure. The discussion around whether indirect measures of arterial pressure is as good as direct is kind of long, and I'm not going to go into that, but I certainly believe, and so do a lot of people, that I think if arterial pressure is one of your outcome variables, you really need to be measuring it directly. And the direct measurements traditionally have included a fluid-filled catheter, and this works incredibly well for a lot of situations. This is something that I have used as well for a long period of time. But more recently, you have solid-state catheters where effectively the pressure is measured at the tip of the catheter and doesn't require the catheter to be filled with fluid. The choice that you use really depends on the experimental paradigm, and quite importantly, at least in my case, the time course of measurement or the time course of the experimental paradigm. So just to highlight, this is just an example of a fluid-filled manometric catheter. In other words, you've got a catheter that sits inside the arterial side circulation, which is connected to this end, and effectively this membrane here transduces changes in pressure hitting the membrane and converts it to an electrical signal, which they can then view in any program that you require. If your experimental paradigm is quite short, for example, if it's an acute anesthetized experiment, or even if it's a conscious experiment, but the period that you record pressure is quite short, you can probably very easily get away with a fluid-filled manometric catheter. The issue becomes, if you're using a fluid-filled arterial pressure catheter, is that over time, as there is some clot that builds up in that really tiny tube, effectively the transduction of the pressure is not as reliable. And here's just an example at the bottom of an animal that we had a fluid-filled catheter in. And you can see at times there's very clear arterial pressure, but you can see the dicrotic notch. And at times, effectively, you lose it. What you find in these scenarios is that if you flush the catheter quite repeatedly, you can get to a point where you see really good output of your arterial pressure trace, but that tends to diminish over time. And usually that reflects a decreasing of the pulse pressure. If you have a paradigm where changes in arterial pressure are incredibly important, or changes in pulse pressure are really important, and you want to be 100% sure that any changes in pressure you see are because of real changes in pressure, as opposed to maybe clots forming at the end of your catheter, and that's definitely one of the primary reasons why effectively I decided to move over to a solid-state pressure catheter. There are a large number of these available in large number of sizes and configurations. The ones that I've used and the ones that I've found quite reliable are the Millar microtip solid-state catheters. And you can see there's a huge variety of them, depending on whether you want to measure arterial pressure in the rodents or you want to go up to large animals. Usually the scenario is that you have this solid-state wire where the essential tip, as showcased here, is what measures the arterial pressure. That goes inside the animal, and the other end gets attached to a pressure box, which then gets converted. There is a lead that goes out to your AC/DC conversion that you can look up in your screen using either LabChart or Spike or whatever program you might use. One of the main reasons why I made this switch from solid state, from the fluid filled to the solid state, And I'll talk a little bit more and show some figures of the kinds of measurements you can get out, is effectively my experimental paradigm necessitated blood pressure recording over days, continuously for a long period of time. And I was always a little bit concerned about what changes in pressure that you might see might potentially be due to clots forming or effectively a change in pulse pressure, which is why, even though a little bit more expensive, we made the switch to go on to solid state catheters, and it's been really helpful as I talk a little bit more. I think blood flow is one of those important physiological variables. It's altered by a large number of mechanisms, and we know that alterations in blood flow occur during both physiology and pathophysiology. So you can have shifts in blood flow from certain organs depending on metabolic demand. For example, if you exercise, you'd like more blood flow to go to your heart and to your exercise skeletal muscles, and you probably have a decrease in blood flow, for example, to your internal organs such as your gut or your kidney. In addition to these normal physiological processes, you also get large changes in flow that might occur during pathophysiology. This is one of the main interests that I have in trying to figure out whether the pathophysiology is associated with the changes in blood flow, or indeed if an alteration in blood flow might explain some of the pathophysiology. A large amount of my interest is in neural control of the circulation. And while I'm really interested in how, for example, sympathetic nerves might affect the vasculature, at the end of the day, changes in sympathetic drive are one of many mechanisms that act to alter blood flow. And I think based on that, in addition to direct recordings of autonomic nerve activity, I've placed a lot of emphasis in my research question that includes measurement of blood flow to answer something that I think is quite important. How to measure blood flow is again a huge a topic. It can be measured non-invasively as well as invasively. You can have ultrasonic, you can have laser Doppler, you can have a huge variety of ways to measure blood flow. Traditionally, also you have the microsphere dilution technique, which can give you point estimates of blood flow. But I think experimentally, in most cases, it's been replaced by measurements of blood flow that allow you to measure blood flow beat to beat. And while there might be a few products out in the market, one of the ones that I've used pretty much since the start of my PhD actually are Transonic flow probes. And the reason why I like them a lot is that they're reasonably reliable, and effectively you can get beat to beat flow. Transonic has a huge variety of probes available. And again, depending on what it is you want to use for, I'm sure the instrument staff can help you with that. You can have really large probes that allow you to put this around the aorta to allow you to measure cardiac output. You have a wide variety of probes that can allow you to measure blood flow to the kidney or to certain vasculature. And of course, one thing that I've started incorporating a lot are some of these probes that have little flange that allows you to measure coronary blood flow, so blood flow going to the heart directly. Some of these are techniques that are very hard in rodents, and effectively that's one of the pushes that I've made towards trying to do this using Transonic. All of these probes effectively get connected to their flow meter, and you can get effectively beat-to-beat changes in flow through an artery of some sort for any period of time that you would like. And there's some incredible advantage to the use of Transonic flow probes. One thing that I guess I should comment on with Transonic flow probes. So one of the things that Transonic really, I think is quite beneficial is that it can give you absolute flow measurements. So effectively, it can give you flow in terms of mils per minute or liters per minute, depending on what vessel you're measuring from. But just a couple of caveats. I think the flow probe assumes an exact diameter of the vessel to calculate flow. I won't go into the physics of how Transonic measures flow, but effectively they're looking at the velocity of blood flow going through the artery. And to be able to be 100% accurate, really you need a flow probe that fits the diameter of the vessel 100% well. And so the point I'm trying to make here is that there is some degree of variability to a group of animals that is not just because of changes in the flow to the vessel, but also might be because of very small but subtle changes in the diameter of the vessel. The implantation of the flow probe is incredibly important because the flow probe needs to be exactly perpendicular to the flow profile. And this is something, again, that if you choose to go down this pathway of this flow probe, I'm sure there's a lot of help and that will be available, or feel free to email me and I'll have my email address included right at the end if you have any questions about how that's achieved. And some really minor things about technical issues, but these are really things that should be sorted out. But you have to be mindful about calibration factors as well as flow probe length, just to allow you to ensure that when you have something that says it is a certain absolute level of blood flow, that is exactly what you're doing. One of the huge advantages I find with transonic flow probe, it is incredibly powerful for within animal experimental designs. So even though you might have some degree of variability here, just because the animal is never going to have an exact diameter artery from animal to animal, but within animal is incredibly reproducible. And that's definitely one thing that I've found really useful with transonic flow probes. And I guess I'm talking about measurement of arterial pressure in large animals. So just a little comment about why larger animals. This is, I never started my research career in large animals, but once I started moving on to a lab that allowed me to work on large animals, I think if you have an interest in cardiovascular physiology, they give you a lot of benefits. This is not to say that rodent instrumentation and rodent protocols aren't important. They are as well. But personally, I think if you want to be able to translate some of your findings, given that the heart rates are closer to humans and cardiac output is closer to humans, there's some suggestion that larger animals, including people, are able to modulate cardiac output a lot more, whereas rodents are more predominantly reliant on changes in resistance. So this is another reason why the use of large animals can be quite important. If you're interested in things that are quite hard to instrument, for example, if you want to know changes in coronary blood flow, for example, that's incredibly difficult and I'd say technically quite hard in rodents, whereas while difficult, it's still accessible for you in large animals. And just to comment that I think some areas are better translatable to humans with large animal cardiovascular physiology. There are a couple of downsides, and it's worthwhile mentioning it, but presumably you have to be aware of this. One of them is cost, in terms of keeping large animals around is more expensive than keeping rodents around. Not necessarily exorbitantly so, depending on what rodents you work on. But the other one that's really quite important is you really need some quite specialized skills. The learning curve, if you want to get into large animal research, can be quite steep and can require quite a few years before you get somewhere that's quite comfortable. But primarily because of the closeness, I think, of the large heart to humans, and because of my interest more in translational cardiovascular physiology, I think the large animal is a really important tool that I have. Okay, so I'll talk a little bit now about implantation of the arterial pressure probe as well as the flow probe. Kind of like I suggested, I'm not going to go into that much detail, primarily because there's some incredibly useful guides out there, especially if your experimental paradigm is slightly different to what it is I might be doing. But just to give you as an example, effectively, if you want to measure arterial pressure, you want to be measuring it somewhere in the arterial tree. So usually anywhere from the aortic arch right along the carotid artery, or if you go down, you can measure it somewhere in the femoral artery. And usually those are the two locations that are quite commonly looked at. What we do is we implant the pressure probe in the carotid artery, or to be more clear, we make an incision in the neck where we can expose the carotid artery, and then this arterial pressure catheter is tunneled into the artery and goes down towards the heart, so it's lying above the aortic arch, but somewhere in the artery. There are multiple ways of doing this, and this is just a very simplified diagram where the carotid artery, the blood flow is coming from the heart and going towards the head. In all of our experimental paradigms, we use a purse string suture, so effectively a little hole in the artery that allows us to insert this arterial pressure catheter that we can then tighten the suture. Some people, depending on the artery they access, effectively tie off the artery and just leave the artery, the probe sitting further down the artery. But in our case, we use a purse string, and that just means that depending on the size of the arterial pressure probe you use, when we use a reasonably thin one, we can measure pressure and at the same time not be occluding any blood flow that's going past that artery. And in our hands, we're reasonably confident that the pressure probe can sit in the artery and not really occlude any flow, because we have some experimental paradigms where we utilize the flow going up to the head, for example, to try and activate some reflexes. Here is an example, and we've got numerous numbers now because we've been using it for about the last maybe 2.5 to 3 years of the arterial pressure profile in an animal where the probe was implanted about 10 days ago. And so one of the beauties of this is that once the arterial solid state pressure probe is implanted, you can get very high fidelity recordings of arterial pressure. You can see that you see the dicrotic notch in pretty much every beat. The other advantage is if you have a fluid-filled catheter, you've got to ensure that there is that arterial pressure catheter is always patent. You can do it a huge number of ways, effectively by ensuring that there's some infusion of heparinized saline through that fluid-filled catheter. And if for some reason that fluid infusion stops and there's some amount of clot, then it makes it really hard to be able to use that fluid-filled catheter again. Whereas in this scenario, because it's solid state, it can stay in the animal and effectively give you very good measurements for as long as you want to. We've gone on with some of our paradigms for about 3 to 4 weeks, and we're really happy in terms of the fidelity of the arterial pressure recordings that come out. As an example, here is another case where we've got an animal that's been implanted with an arterial pressure probe, and I don't know exactly how many days, but I'd say probably a week. You can see there's an arterial baseline level of arterial pressure, and in this animal, we've been infusing phenylephrine, which is an alpha vasoconstrictor, intravenously for this period of time, and you can see this slow and steady increase in arterial pressure. The thing I want to, I guess, focus on is you can see this increase in pulse pressure, which allows you to be sure that this dose of phenylephrine is actually increasing pulse pressure. Sometimes changes in pulse pressure with the fluid-filled catheter are a little bit harder to see, especially if that catheter has been in place for a long period of time. So just another additional advantage of a solid state arterial pressure catheter, where I think you can be more sure of changes in pulse pressure that you might see over a long period or an acute period of time. Okay. The instrumentation for blood flow is a lot more complex because it depends really on where you want to implant your pressure probe. In other words, which blood vessel you want to go to, whether it is the aorta to measure cardiac output or it's the renal artery to measure renal flow. We routinely put these cardiac output flow probes in the ascending aorta or the pulmonary to record cardiac output now. And here's just a schematic showing effectively you need it to be reasonably perpendicular to be able to measure absolute blood flow. I'm not going to go into the details of exactly how we implant flow probes in all the different blood vessels, but if that's an interest, I'll give you some examples of what we have done. And if you're really interested, feel free to come get in touch with me, or I'm sure any of the AD instrument staff would be able to help you with that. And so here's an example of an animal. This would be maybe about 7 to 10 days after surgery, where we're measuring arterial pressure through a solid state pressure transducer. We're measuring beat-to-beat cardiac output as well as coronary blood flow, so blood flow going to the heart. So again, reiterating the ability to measure coronary blood flow, which kind of, not that I need to justify it, but justifies the use of large animals in research. The fact that you can measure these beat to beat in conscious animals that are standing in their home crates or home cages is just a really big plus to be able to measure all of this. We usually are just looking at changes in flow or cardiac output or pressure over a period of time, but you can also look at some really in-depth analysis. For example, I've just blown up this exact figure here. So you can see the time relationship between the blood's coming out of your heart for cardiac output versus the arterial pressure trace in the carotid artery, and you can see a little bit of a delay. And the really important thing about coronary flow, of course, is that the increase in blood flow to the coronary artery really happens during relaxation of the heart. So it's during diastole that you get an increase in coronary flow. So these really little things that you can get out or measure with beat-to-beat measurement of coronary flow is what makes these transonic flow probes quite important and useful. There's a huge amount of research, and I'll just comment on it, where people are looking at the profiles of coronary flow and how might that alter with pathophysiology. And of course, the use of these transonic flow probes really allows one to do that. Here's another raw figure, if you like, where in this animal we've implanted again an arterial pressure probe, but we are simultaneously measuring blood flow to the renal artery, so measuring blood flow to the kidney, as well as hind limb blood flow. So this flow probe is attached in the distal aorta, just post the renal artery, and effectively all the blood flow from there is going through the mesenteric to the skeletal muscle, and effectively that allows you to look at skeletal muscle blood flow as well as renal blood flow and changes that might occur with different paradigms. So effectively, just to highlight that, blood flow is just this incredibly useful measure, I think, that you can measure in a whole host of organs depending on the experimental paradigm. Before I go on to talk about a couple of my research models and how we have utilized these tools, just kind of want to reiterate tailoring your tools to the research question. This again maybe is quite basic depending on who's attending the webinar, but I think it's for you to decide what physiological variables are important to measure depending on your experimental protocol, whether it's acute, whether it's chronic, whether it's anesthetized or it's conscious. You can then decide whether you want to look at arterial pressure with a fluid filled or solid state, or indeed if you want to move towards the transonic flow probes. And I think it all really depends on the research question that you're trying to answer. And definitely my research questions have kind of slowly moved more towards how changes in flow might explain pathophysiology a little bit. That's why I've moved towards the solid state as well as transonic flow measurements. So that's all I'm going to talk about in terms of the tools we have, the instrumentation techniques, as well as which tools you might pick. I'm then going to go on and give a couple of examples of a couple of models of pathophysiology that we have in the lab and try and explain how these tools have allowed us initially quite simplistically, but then with a lot more detail, try and unpick what's happening to explain the underlying physiology. So for a long period of my time in my career, I've been really interested in heart failure, which basically is a condition where the ventricles fail to eject adequate quantities of blood to move the mass of the body. I'm going to focus my work really on heart failure with reduced ejection fraction, where effectively ejection fraction is below usually 40%, as opposed to heart failure with preserved ejection fraction, which also comprise about 50% of the population, but that's a separate story that we're going to talk about today. The symptoms when you have reduced ejection fraction are fatigue, breathlessness, and mental confusion. Within New Zealand, there's about 80,000 people, and the numbers are similar per capita for most countries. It is the #1 reason for admission to the hospital of people who are over 65. And 6% of all acute admissions are attributed to this cohort. The prognosis, I'm not sure you can say it's worse than many cancers. I think it's getting close to that of many cancers. But effectively, the 5-year mortality rates, the 59% for men has come down a little bit, but still remains 45 to 50%, depending on which country you look at. So prognosis is quite worse for these patients. And of course, the reasons that cause it can be varied from ischemic heart disease to high blood pressure or cardiomyopathy. So within this paradigm of heart failure, if you look at these heart failure patients, one of the things that people have noticed for a long period of time is that if your heart rate is not variable, or effectively, if your heart rate variability is low, effectively it's associated with very poor outcomes. So this is just comparing a group of patients, stratifying them into whether their heart rates are really variable or very static and do not vary a lot. If your heart rates don't vary a lot, the prognosis of the patient is quite poor of this cohort of patients. One of the things that drives this lower variability in heart rate is effectively impaired baroreflex function. Where effectively the baroreflex is unable to account for changes in blood pressure by alterations in heart rate. And usually if you're developing a model of heart failure, one of the really important things you're interested in is whether baroreflex control is impaired. I won't go into the details of why we decided to choose the microembolization model of heart failure, but suffice it to say that we had a large number of research questions that were looking at processes that occur that alter autonomic function in heart failure. It's the research question just for this talk that we had was, does the microembolization model of heart failure replicate the baroreflex dysfunction that you see in a large number of heart failure patients? With the hypothesis that yes, it does impair it. In order to be able to look at baroreflex function, effectively you alter blood pressure and then you measure the effective heart rate. In order to be able to do that, what we did was we utilized the solid state Millar pressure catheters that were implanted in these groups of animals to effectively look at that. So just as the methods, effectively, these are sheep, large animals. So once they come into the lab, they're given about a week to acclimatize. We then do about 3 embolizations a week apart. So effectively in the embolization, a catheter is inserted in the coronary artery and really tiny microspheres are put into the coronary arteries that effectively cause a diffuse heart attack. This might be repeated 2 or 3 times. So they have 2 or 3 MI episodes or myocardial infarction episodes. Then they're given a large period of time for heart failure to develop, which we can confirm using echocardiography. Once they come back, we instrument them in the animal. We instrumenting them with cardiac output and coronary blood flow in order to be able to answer some research questions. I'm not going to delve into those. There's not enough time today, but effectively what I'll focus on is at the same time, we also put an arterial pressure probe. And once the animal is recovered from surgery, we can do some experiments. In this scenario, we're looking to see if baroreflex function is impaired. We know there is a good model of heart failure because the ejection fraction, the amount of blood pumped out of the heart is reduced, the fractional shortening is reduced, and the hearts tend to be a lot larger in these heart failure animals. There's a fair degree of fibrosis, which we can confirm by looking under the microscope. You can see the amount of collagen goes up in these animals. In addition to changes in heart parameters, you can see there is in this cohort of animals quite a large reduction in mean arterial pressure as well as an increase in heart rate. So increase in heart rate and a decrease in arterial pressure is very reminiscent of what you might see in a patient cohort of heart failure. And of course, we can measure BNP and plasma norepinephrine levels, and these are elevated just as you would expect in patients as well. In this paradigm, now we've established a model where it kind of fulfills, at least in terms of heart dysfunction, what you might expect to see in an animal model of heart failure. And then we challenge these animals where we increase blood pressure using IV infusion of phenylephrine, which is very similar to what I showed you earlier. And then we decrease blood pressure using sodium nitroprusside, and we can plot the resulting changes in heart rate. So effectively in black is a control animal, and you can see as you increase blood pressure, heart rate falls. As you decrease blood pressure, heart rate increases. Interestingly, in this heart failure cohort of animals, this alteration in blood pressure around the resting value is low. So there's a reduced gain. In other words, changes in arterial pressure don't affect heart rate as much, as well as you have a reduced lower plateau. We can view this a different way, and effectively you're sitting at your control level of blood pressure. As you increase pressure by 3 or 6 millimeters of mercury, in the control animals, you've got a certain change in heart rate. Now that change in heart rate is diminished in the heart failure animals, whether you increase or you decrease blood pressure. So effectively, again, a different way of highlighting the previous scenario, just to reiterate that effectively you do see an impaired barrier reflex function in these animals. And now, having established the impaired barrier reflex function, we now have instrumented these animals with cardiac output, coronary flow, arterial pressure probes, and then we're going on to answer some research questions about, for example, the effects of alteration of respiratory sinus arrhythmia, etc., etc. I won't go into the details of all the research questions we have, but effectively, initially we have the use of arterial pressure to give us a result, which is impaired barrier reflex function, and the use of these probes is going to allow us to really interrogate some important questions about pathophysiology in heart failure. In addition to heart failure, one of the important arms, if you like, of my laboratory is they're looking at hypertension, because it's a huge problem affecting about 40% of adults. It's a leading risk factor for death and disability associated years lost. It is a huge cost. For every millimeter of mercury increase in blood pressure, the risk of death goes up. And for every decrease in blood pressure, you're able to do, you decrease your risk of ischemic heart events as well as a stroke by substantial amount. Even though we have a large number of medications available, unfortunately, about 60% of patients that are prescribed antihypertensives have inadequate blood pressure control. Some of this is because some of these patients don't take their pills regularly. Some of it could be because the dose of the pill isn't right. And a small cohort of these patients, even though they take the pill and it is the right dose, they're just refractory to blood pressure control. In other words, the pills just don't work for them. It is highly relevant, but incredibly poor understood. And one of the issues with hypertension, as opposed to, for example, a heart attack, is that when you have hypertension, you don't really physically feel any different. If anything, you might actually feel a little bit better because you have high pressure and therefore high flow to a lot of your organs. And so it just means adherence to medication can be quite low. Why do a lot of these patients get hypertensives? One of the things we're really interested in is whether there is an increase in sympathetic drive that might go up to various organs. We know that in humans, if we indirectly estimate cardiac sympathetic drive using the spillover technique, there's a large increase in spillover. One of the first studies we did was to try and directly record from sympathetic nerves going to the heart to ask the question if there is an increase in directly recorded cardiac sympathetic nerve activity during hypertension. And of course, the hypothesis is that we would see an increase. So very quickly running through these methods, in this case, we've got a group of normal and a group of hypertensive sheep, where after the animals come in, it's a 2-kidney, 1-clip model of renovascular hypertension. So effectively, we clip one of the renal arteries, let the animal go for about 2.5 weeks, and we're recording blood pressure using a solid state catheter, as well as we're going to record some sympathetic drive. You can see that after the artery is clipped, the weight of the kidney falls, whereas the contralateral artery tends to compensate. And we have a large increase in blood pressure with no changes in heart rate. Now, you could probably potentially see this difference with fluid-filled catheters, and people have seen this before, but the use of the solid state really gives us a little bit more reassurance that the measures of arterial pressure we have, especially for some chronic experiments, and I'll come to that in a little bit, are real. You can give ganglionic blockade that effectively blocks sympathetic drive to all the organs, and you can see the drop in blood pressure is larger in the hypertensive animals. And that's because if you directly measure cardiac sympathetic drive, so this is arterial pressure, there are these bursts of activity going along the cardiac sympathetic nerve. And you can see just in this animal, the number of bursts seems to be elevated to the heart, but if anything, seem to be reduced to the kidney, and our mean data effectively replicate that. So initially, we showed that this model of renovascular hypertension is associated with an increase in cardiac sympathetic drive, but actually a reduction in renal sympathy. This increase in cardiac sympathetic drive appears to at least modulate some degree of heart rate in these hypertensive animals. Okay, so we established this model of heart failure, looked at some changes in sympathetic drive. The second question is, well, what might be mediating this hypertension in this model? And one of the things we were interested in were the carotid bodies. So the carotid body, a pair of organs located at the bifurcation in the neck, at the bifurcation of the internal and the external carotid artery, and effectively they sense changes in hypoxia, changes in pH, changes in PO2, PCO2, and some recent evidence they're polymodals because they can sense a whole host of things. There was some evidence in rodent studies that interruption, so removal of the carotid body or interruption of the carotid sinus nerve might reduce blood pressure in rodent models of hypertension. So we want to look at what is the role of the carotid chemoreceptors in mediating hypertension. And our hypothesis was that if we cut these carotid chemoreceptors, we would reduce blood pressure. Very similar methods, except in this case, we're primarily looking at renovascular hypertension, where we are clipping these animals, but at the end, we either do a sham or a denervation of the carotid sinus nerve, and then look at changes in blood pressure. One of the reasons why the solid state pressure catheter became incredibly important is we were measuring arterial pressure for a long period of time before the sham or the carotid sinus denervation. The first couple of animals we did with fluid-filled catheters, we saw changes, but also associated with a change in pulse pressure. So one of the worries was also with the fluid-filled catheter was whether any changes we see might be reflected to an increased incidence of clots in the fluid-filled catheter, which is why we made the shift to the solid-state catheter. The way we test for denervation of the carotid bodies is effectively we give a stimulus called potassium cyanide, and if the carotid sinus nerve is intact, there is an increase in blood pressure. Once we have effective carotid sinus denervation, blood pressure doesn't increase as much. What was really interesting to see was in the group of animals where the carotid sinus nerve was cut, we see this large reduction in mean arterial pressure after the carotid sinus nerve is cut. But if you expose the area but don't cut the nerve, you don't see any change in arterial pressure, effectively indicating that removal of the carotid chemoreceptors can decrease blood pressure in this cohort of animals. This was quite a puzzling result for me. I mean, people have shown this in rodents before, but the puzzling result for me was why should the carotid chemoreceptors be involved when the insult is happening in the kidney? I mean, the assumption is that usually the blood pressure would go up because of renal ischemia, because of the renal angiotensin system, which might increase sympathetic drive. But why the carotid chemoreceptors were hyperactive was always a puzzle for me. This is just looking at Baraflex control. I'll just skip over this. And really, we kind of thought a lot about why the carotid chemoreceptors might be hyperactive. In animal models of heart failure, where cardiac output is really low, you see a decrease in carotid blood flow. And the assumption is that that carotid blood flow decrease might also decrease blood flow to the carotid body, which might be why the carotid chemoreceptors are really, the activity of the carotid chemoreceptors is really elevated in heart failure. So we chose to look at this in a hypertensive model as well. This is just hemodynamic variables. I'm just highlighting mean arterial pressure in the normotensive and hypertensive group. You can see the hypertensive group mean arterial pressure is greater. To our surprise, carotid blood flow was actually significantly decreased in this hypertensive group. I didn't really expect this because normally you expect if mean arterial pressure is greater, if anything, blood flow should stay the same or maybe even increase slightly. But we saw a large decrease in carotid blood flow as well as a decrease in carotid vascular conductance. So here's where the use of, for example, the transonic flow probes really allows us to have some insight into why the carotid chemoreceptors might be really important, at least in this model of hypertension. And the solution, or the likely solution, might be that renovascular hypertension is associated with a decrease in carotid blood flow, which might be one mechanism that increases or elevates hypertonicity of the carotid body. So just to conclude kind of the scientific talk, using the tools, we've shown that renovascular hypertension is associated with a significant increase in directly recorded cardiac sympathetic drive. If we cut the carotid sinus nerves, you can reduce mean arterial pressure, and the use of solid state pressure probes where you don't really see any difference in pulse pressure over time allows us to be really sure of this result. And of course, the measurement of carotid blood flow and conductance allows us to posit that it might be that a decrease in carotid blood flow may underlie the hypertonicity of the carotid body. I'd just like to finish by acknowledging a large number of people who have been involved in a lot of these projects. So in terms of research from the University of Auckland, postdocs, as well as PhD and postgraduate students, Dr. Nigel Lever, who's a clinician who helps a lot with the heart failure project, technical staff, and of course, a huge number of funding sources without which this work wouldn't be possible. And finally, I'd just like to end by thanking again Amy and Nick for giving me this opportunity to talk a little bit about my research, as well as highlighting the use of tools such as the arterial pressure, as well as the transonic flow probes to be able to look at different research questions. If you have any questions that you come up with later, I'm happy to be contactable by email. You can just flick me an email. I'm happy to get into any discussions or collaborations if required. Almost all of this work has already been published. There's some upcoming, but if you're really interested, you can look up me on PubMed if you want to get a few more details about either experimental paradigms or the use of these tools. So I'm going to end it there and happy to take any questions if there are any.
Thank you so much, Dr. Rohit Ramchandra. If I could just share my screen, we also have some contact details for our team as well. And we are open to questions. Just waiting on them. I start off in, I suppose. Are you also looking into different types of, different frequencies, like low frequency or high frequency, very low, very high frequency, depending on if that has any sort of effect with the blood pressure regarding the heart rate variability? Just with the heart rate variability, are you also interested into the low frequencies or very low frequencies that could be affecting baroreceptors here?
Yeah, so I haven't really looked at high or low frequency oscillations in blood pressure. I know quite a few people who do that quite routinely. And of course, that would be quite useful to have really good measures of blood pressure in that scenario. So I haven't really looked at low or high frequency in arterial pressure. There's a whole host of papers that look at low and high frequency power in heart rate. And I've published a little bit on that. I'm not that convinced that low frequency oscillations in heart rate variability tell you much about sympathetic drive. And I've got a few publications around that. So I'm interested in heart rate, low and high frequency variability, in its use as an experimental tool, just because it's so easy to get heart rate from, especially from clinical patients, but blood pressure, not as much.
And we have one now from an anonymous attendee. I'll just read you out the question, Rohit. I'm curious about the solid state versus fluid-filled catheters. How much does artery size affect how good your fluid-filled catheter's signal is? Or is it that your experience that solid state is generally better? Is there any function of experiment length?
Thanks for that question. So how does artery size affect fluid-filled catheters? I mean, theoretically, I would assume that the larger the artery size, potentially your fluid-filled catheter will work better for a longer period of time. That's an assumption. I'm not sure if that's true. Usually we go for the carotid artery, which would probably be one of the larger arteries in the sheep, and I suspect in a whole host of animals as well. And even with the carotid artery, there are a whole host of factors as to why fluid-filled catheters don't necessarily work that well. But one of the primary things is that the longer you wait, the more the time for something to go wrong. One of the things that happens with fluid-filled catheters, if you've got to be constantly and continuously perfusing this fluid-filled catheter with enough heparinized saline to ensure that you don't clot. And if for any reason that gets interrupted, or for any reason that gets blocked for any period of time, especially in the arterial side of the circulation, it makes it difficult, and it makes it quite, it makes me question results sometimes. So in my hands, at least for experimental paradigms I use where I'm going more than a week, I just think solid state catheters are better. And it took me a while to be convinced, if I'm honest, but now that we've made the change, I think it's very hard for us to go back, just because we can see it works so well.
Yes, I can attest to the same thing as you have, Rohit. I did quite a lot of rat studies, and where we had fluid-filled catheters as well, and we also had blockages, and you could see that the effects that has on blood pressure and also the actual trace itself. I can ask another question if you like, Rohit. Yeah. In terms of just your, how easy was it actually to use the flow probes and themselves? Like, was it much of a learning curve there you found, or just fairly easy to even teach your students?
I think with the flow probes, it depends a little bit on which flow you want to measure. I'm assuming some underlying level of surgical expertise. So you're able to, in the anesthetized animal, go in and expose the artery. If you're looking at probes that are quite small, for example, the renal artery, skeletal muscle flow, I think it's incredibly simple. I think in some ways, putting an arterial pressure probe, I think would take more time and potentially be more problematic, I suspect, than putting in a flow probe, for sure. I think some flow probes are a little bit harder. So I think if you want to put a carotid artery, a cardiac output flow probe, so going around the aorta or the pulmonary artery, those can be a little bit more difficult, just because you're dealing with the beating heart constantly. And also it's a little bit harder to be sure that the probe kind of fits around the aorta quite well. So those require a little bit more time, but I would say they're still incredibly easily doable. I mean, you might have to do a couple of acute anesthetized experiments to just get into the swing of things, if you like. But I didn't find them that hard. The only caveat to all of these would probably be coronary flow. So coronary flow is hard, not because the probe is hard to use, but I think what it is you're trying to clear the coronary artery is a little bit more difficult because of the beating heart, as well as the potential that if there is a bleed, it can be quite fatal in terms of the animal. So the coronary flow, maybe you need a little bit more guidance, or potentially to go somewhere, actually learn the technique. But all the other flow probes, I think if you have some level of surgical skill, I think they'd be incredibly simple.
Thank you, Rohit. We have another question here. How do you make sure that there's no blood clot when you inserted the catheter in the particular artery? Did heparin would help at this point?
So I'm not sure if the question refers to a fluid-filled or a solid state, but I can answer both. So in a solid state, effectively, as soon as you put it in and close the purse string off, usually you'd see blood flowing past that artery effectively. So you're reasonably confident that there's no blood clot. With the fluid-filled, if you have a clot that forms exactly at the tip of the sensor, then my assumption is that that would affect your blood pressure reading. But in the animals we've done in the last 2.5, 3 years, I don't think we've ever had a scenario where there's been a blood clot on the solid state pressure tip. In terms of fluid-filled catheters, as soon as they're inserted into the artery, effectively you can flush in and out. And effectively, as long as it bleeds back well and you can flush in well, you're kind of confident that there is no blood clot. I think if you can't withdraw or you can't flush in, clearly there's a blood clot. You have scenarios where you can flush in, but you can't withdraw. And I think those scenarios as well, for me, tend to be a bit problematic because my assumption is there is some clot or potentially a flap of a clot right at the tip of the fluid-filled catheter. And usually my experience is in those scenarios, you can kind of flush heparin and keep it patent. But usually as you keep flushing, your pulse pressure trace improves and tends to degrade over time.
Thank you, Rohit. Yep. We have another question here by James Hong. Have you tried using LA telemetry transmitters, which allows a more natural animal behavior and work with conscious animals? If yes, have you seen any significant difference in data?
So I haven't used LA telemetry transmitters. I have experience with some telemetry pressure transmitters, and that's mainly what used to be telemetry research, and now I guess it's the Millar, or used to be Millar, and maybe it's changed. But once I move to the large animals, we don't really use telemetry at all. Just to make that distinction, I don't think you need telemetry to do conscious animal experiments. Definitely not in the large animals. So all of the data we see are in conscious animals for long periods of time. It's easier perhaps than rodents, but you can do conscious animal experiments without the need for telemetry, which is why we haven't made the change. I know pressure is available with telemetry, and last I saw even flow is available with telemetry. It was something we considered, but conscious animals meaning free roaming. That's a fair point. So they're not quite free roaming, but they are tethered. So all the probes come out of the back of the animal and go together in the probe right to the back where they connect to various things. We very rarely would allow the animals to roam in large areas. That potentially is an experimental paradigms you can use. But effectively, they're allowed movement within their crate, but not enough for them to be able to get access to the probes coming out.
Thank you for that answer, Rohit. And just waiting another minute if anyone else has any questions. Otherwise, of course, you can email us or Rohit directly. Can I ask you one more question regarding the catheters? How long, in terms of durability, how long does a catheter last, in your opinion?
So in an individual animal, we put these catheters for some of our protocols have gone up to maybe 3-4 weeks, and we find them reasonably durable. Some catheters are meant to be reused. Some catheters are meant to be single use only. But in our hands, even the single use catheters, you can keep using them repeatedly. I think you've got to be very careful with that, the solid state tip, which is what measures pressure. Because I think when, especially at the end of the experiment, when you get these probes out, if you damage them in any way at all, then I think it's likely that it's not going to work again. And that's taken a little bit of, I guess, upskilling in our scenario, where especially students can be a little bit more rougher. But I think if you're careful with it, we just keep reusing them. Both the tip as well as where the wire kind of joins up into where it gets connected to the cable to the box. I think those are two kind of, if you like, points that you've got to be quite careful about. We've used them in multiple animals. The thing that we do quite routinely is we check the zero before implantation as well as the end when it comes out. We see very minimal changes in zero levels, which is again another reason why we are quite confident that the pressure levels we see are quite good.
Fantastic. Thank you very much, Dr. Rohit Ramchandra, for the webinar and to answer these questions for us. And once again, contact Rohit directly or our team if you're interested in any of our products. So we'll be finishing off now, and this is of course recorded, and we'll be sending it to everyone. So once again, thank you, Rohit, and we'll see you all again. Thank you.
Cool. Thank you.
Oh, okay. Bye-bye.